Mental Health Dialogue series. It is a pleasure to have you join us for this session titled Culture, Stigma, and Community Rethinking Narratives plus Lessons from MHDS. The Mental Health Dialogue series creates a space for open, meaningful, and informed conversations about mental health, bringing together different voices and perspectives to help us better understand the issues that affect individuals, families, and communities. Today's conversation focuses on the ways culture, stigma, and community shape how we understand mental health. It is an opportunity to examine some of the narratives surrounding mental health, challenge misconceptions, and reflect on how we can build communities where mental health is discussed with greater understanding, openness, and compassion. We are honored to have two distinguished guests joining us for this session. Our first guest is Alex Gomachab, a psychologist trainee registered with the Health Professions Council of Namibia, who is working towards becoming a behavioral neuroscientist. Alex is the founder of Wellness and Healing, an online mental health awareness platform focused on demystifying stigma and challenging myths surrounding mental health through evidence-based knowledge. With 5 years of experience in the mental health space, Alex has been actively working toward the normalization of mental health conversations, particularly within rural and vulnerable communities, while advocating for greater accessibility to mental health services and care. Alex is also currently conducting research into the impact of father absence on psychosocial development and maladaptive behavior among emerging male adults. His work aims to contribute to policy development and guide meaningful community interventions. In addition to his work in mental health, Alex holds a Bachelor of Marketing degree and serves as a brand ambassador for Be Free Movement, a youth-centered initiative founded by the former First Lady of Namibia. We are also pleased to welcome Mrs. Musarat Rani, a gold medalist in psychiatric nursing and an experienced RMN-CAH professional with more than 20 decades of experience across mental health, maternal, child, and adolescent health. Ms. Rani is the CEO of Irshad Amtul Reproductive Health and Midwifery Services, where she leads community-based health interventions across Pakistan. She also serves as MNCH specialist with various organizations. Her areas of expertise include mental health first aid, maternal, newborn, child and adolescent health and nutrition, gender-based violence, sexual and reproductive health and rights, and the prevention of early child marriage. Ms. Rani has developed culturally grounded health manuals and pioneered e-health solutions within maternal, newborn, child, and adolescent health and nutrition. She has also collaborated with organizations including the World Health Organization, the International Confederation of Midwives, NFPA, and the Ministry of Health on national RMN-CAH agendas. We are grateful to have both of our guests with us today and look forward to the insights, experiences, and perspectives they will bring to this important conversation. And now, to guide us through today's discussion, it is my pleasure to introduce our host and moderator, Owinsike Victor, a public health expert, mental health advocate, and researcher. Victor will lead the conversation and help us explore the questions, experiences, and perspectives at the heart of today's theme. With that, I would like to hand over to Owinsike Victor to officially begin this session of the Mental Health Dialogue series. Thank you, and once again, welcome. Good afternoon, everyone, and welcome to another session of the Mental.
Good evening, everyone. It's a pleasure to have us here again. Thank you so much for joining us on this session. This particular uh, conversation is very dear to my heart, not only because we're discussing an important topic on mental health, but also we are bringing this particular dialogue series to a close. Over the course of this series, we have looked at mental health from different angles. We started a few months ago when we talked about evidence to action, bridging research and community solutions in mental health, where we asked how we move beyond producing evidence to actually creating solutions that communities can use. And also, our next series was focused on bridging research and reality, mental health in low and medium income countries, where we got to look at mental health not simply as a health issue, but also as a matter of rights, dignity, and equity. And we also looked at technology. Is technology able to help us close the mental health gap? And tonight, we are at our final conversation: culture, stigma, and community. Plus, rethinking narratives, what we have learned over time, from evidence to action down to this. And we are not ending this series because this is the end of the conversation. No, we are moving into more, because right now we have evidence, we have policies, we have technology, we have resources. So we know that mental health is experienced by many people, families, cultures. In fact, it is our everyday reality. We say there is no health without mental health. So today, before we start our conversation, I'm throwing this to our audience, to even our speakers here. When we talk about mental health, whose narrative are we actually talking? Which narrative are we using? Is it from the community? Is it our own? That's our personal ones? Or is it the one that is set as a gold standard by World Health Organization? Whose definition do we use? What happens when the designs that we think a community needs is not serving them? Do we listen to them, or do we do what we think is right by the books? So this is the conversation we're going to have tonight. So thank you so much, our speakers, for joining us today, Mr. Alex and Miss Rani. So in 1 or 2 minutes, I wish to give our speakers just a platform for them to tell us what they understand by mental health in our communities. So we leave the floor for Miss Rani. Thank you.
Okay, thank you so much, Miss Victor. I would like to ask your question again because there is some disturbance when you are talking. Uh,
Okay,
Thank you.
I said, what is mental health to you from your community? You have worked with communities, you have worked in the hospitals. What is your definition of mental health?
Okay, thank you so much. So, Miss Victor, according to my work experience, mental health is different for the different people. Like, as you know, we are living in the different communities, and the communities taught me that mental health is not, we can fit mental health definitions according to the WHO definitions. Because in some people, mental health is simply a spiritual thing. In some societies, they are taking mental health as a cultural or the behavior problem, and in the some communities, they are taking mental health is totally a character problem. So according to my work experience, mental health is different things according to the community perspectives. The most important thing is how we are taking mental health as a psychiatrist or mental health healthcare providers in the community. So, communities taught me that the definitions is very good, which is given by the WHO. But the things which are used to treat the mental health problems or to identify the mental health problems from the community is different, which researchers has been shown, which policymakers have been well, or the practitioners are applying. So according to the my work experience, mental health conditions are different. And my second answer is this: according to the different groups, like perinatal mental health conditions are different. According to pregnant women's and the lactation movements perspectives, mental health is different. According to the adolescent point of view, mental health is different. So, according to different groups, according to the communities, mental health definition is sometime and somehow is different from the its original definition. Thank you.
Thank you so much, Miss Rani. So we go to Mr. Alex. Miss Rani has told us that mental health definition is different according to the groups and the communities you find yourself. From your experience, what is one thing you wish that the mental health community or mental health experts understood better about communities? Hello, Mr. Alex, are you with us? Hello, can you hear me? Okay, while we wait for Mr. Alex to rejoin us, it seems he's having a little challenge there. We're going to dive back into what we are talking today. We wanted to understand our community and how we define mental health for this to be a good place for us to begin. So, we're going to start with culture. How does culture shape the way people understand, express, and respond to mental health challenges?
Okay. Uh, as Miss Victor come back, I think there is some technical problem. I can give answer to how does the culture shape the way people understand, express, and respond to the mental health conditions. And I think I just start to give answer, Miss Victor.
Okay, please. Yeah, I said, how does culture shape the way people understand, express, and respond to
Mhm.
mental health challenges?
Yes, I believe that the understanding of the culture is also very much important to understand the mental health conditions also. First, we must know what is culture. Then we can understand what is the mental health according to the culture. Because different societies understand and experience mental health challenges in a different way. For example, some people may not describe their mental health condition as according to our criteria as a healthcare mental health care providers. They may express their mental health condition in their physical sign symptoms like they are tired, they don't have sleep, or they may have some family issues, and maybe they have severe headaches. So they show their mental health problems in their physical situations. In many other communities, family, religious tradition, and the social values also very much important to show their mental health conditions according to their culture. No, everybody is show their mental health condition in a same way. Different societies show their mental health conditions according to their beliefs, according to their culture values, according to their family structure. So we can't fit all signs and symptoms and beliefs in one frame. However, sometimes our conventional methods misunderstood and misprint their sign symptoms, and they mislead to the people because they use some kind of tool that totally didn't understand what are the mental health sign symptoms and what are their main conditions. So somehow some cultural values and some family values didn't exactly show the mental health challenges which are showed by the people. So first we understand different cultures, society, people, communities to understand the different mental health conditions. Therefore, instead to using the one fit from um, framework for all approaches, we need to mental health services that take into the account people's local culture, language, their family systems, beliefs, and the culture. Then we can understand and we can express and we can respond to the mental health challenges according to different cultures. Thank you.
Okay, thank you so much, Miss Rani. When you talked about understanding the culture of the community, are there cultural practices in this community that actually protect mental well-being of the people?
Sometimes the cultural values didn't protect the mental health when mental well-being of the people. Sometimes cultural values create mental illness into the people, like like some we can say some kind of their cultural behaviors, like in some societies female not allowed to check by a male person in any kind of conditions, in any kind of condition. In this situation the female suffering from different kind of stresses, different kind of frustration, and even in some medical condition are so serious, they ultimately on their mental health, resulting rather than they treat their medical condition, they are suffering from different kind of mental health conditions, like perinatal mental health conditions. In many societies females are only suffering in the perinatal health condition due to not getting treatment by the doctor because their culture don't allow.
Oh,
This is a very simple example.
wow, that's quite
Thank
sad sometimes if you think about it. And we've actually heard where some people cannot even communicate what is wrong with them because based on their cultural
you.
upbringing.
Miss Victor is breaking. I'm sorry, your voice is breaking.
Okay, can you hear me now?
It
Hello.
is still it is still
Is
breaking.
Oh, okay. Mr. Alex, are you with us now? Can you hear me?
Yes, I can hear you. Can you hear me?
Yes. Okay. So, Miss Rani, can you hear me now? Is it okay? Hello, Miss Rani. Can you hear me too? All right. So, with that, we'll move on to Mr. Alex. With what Miss Rani said, does this resonate with you in your practice, in your research work in communities?
I was not able to get the full. I think the first question because of the network issues, but I do believe that we do share some similarities. I just did research last year. In that research that I did last year, one of the main things that came up for me was the lack of concepts about mental health, the lack of concepts, in a particular language. So people did not have words for feelings like anxiety, words for mental health disorders like depression, um, or what is this PTSD. They did not exist. People also did not have words for things that we take loosely like stress. But as Dr. Rani was saying, that they would describe these things in physical terms. So you had to kind of like deduce what this person was saying. I had profound sadness, or I had long periods of sadness, or I had a lot of worry or fear associated with the future, or those things. So people do not actually have, most African languages do not actually have specific words like the Western languages have for feelings like depression and anxiety and loneliness. Okay, loneliness is there, but frustration, because for example, in my country, frustration would also be translated into anger, or irritability could also just mean anger. So it takes a lot of deducing and understanding what the person is actually saying. There is one thing that I've experienced with my research, and when I actually see people, the lack of concepts or the lack of terms that they use to describe how they're feeling and how they describe their mental health. I would also add, and I also agree that the definition of mental health also differs from community to community, but also from age group to age group, and also from gender to gender. For example, some people would still, a majority of people still view mental health as mental illness. And they would treat, whenever you talk about mental health, they automatically say, but I don't have a problem. I'm not stressed. I'm not depressed. I'm not crazy. And whenever you also talk about mental health, they automatically also think that the remedy for mental health, for example, would be going to see a traditional healer because you have been deep possessed by a demon. So from culture to culture, from age group to age group, while the younger generation is more woke and more understanding of what mental health would be, the middle age and the adults who are still in that space where they view mental health as um, something that is associated with, or just with mental illness. What I and a few people are trying to do is just to introduce and reintroduce, the WHO definition of mental health, not in its entire sense, but breaking it down into its different parts. What does it mean to mental well-being? To be able to cope with stresses of life, realize their full potential, contribute to the community, so that a person is able to understand and see what it means to contribute to the society, and also highlighting the limitation of that definition. It's in saying that you do not also need to contribute to your community to have mental well-being, but that aspect is there in to just guide you to have a holistic mental well-being. I would also like to add, when you were saying the last question, when you were saying is because my network, about what community practices are there that promote, or that are the protective factors of mental health. And I would say one of the most important things that I've seen within the communities within Namibia is the sense of just community, the word community, where people can come together and just share their grievances, or share their losses, or especially when it's, maybe for example, when it comes to climate change and having lost a lot of animals, or having lost a lot of crops, just to come and share their grievances and loss. It has actually helped them also to find a way to deal with this and find solutions for having that loss and experience, and have like this kind of a community or a collective healing space where they can grieve together and find solutions for their problem together. I think community is one of the most important things that I've seen when it comes to community, when it comes to the protective factors that communities can offer. I think that is what I
Oh,
miss.
okay. Thank you so much, Mr. Alex. That was a question I was trying to ask Miss Rani. That does language actually influence how these people seek for help? Because they might not be able to explain what they are feeling in clear terms, and they might just be having signs, symptoms like this. And does it really make them say, oh, because I don't know how to express myself, so let me just let it go? Does it really influence them? Hello, Mr. Alex.
Oh, is it for me? I
Yes.
do I don't think I think it also plays because they don't understand. The thing with not having the correct terminology within our languages is does it also places that burden of not knowing or understanding what you are really suffering. So, for example, a lot of people would be suffering with mental health challenges, but they would not think that it is something that is wrong. One of the things that also within our communities is very prevalent is that intergenerational um, struggles that are associated with mental health that have been experienced by families for a long period of time or through generations. For example, every family member, for example, has gone through depression, but they have not seek mental health, and they have found some way to function with this depression, and they start to normalize it and see it as something that is normal. So seeking help, I would not say predominantly is limited by language, but I think it is also limited by when you merge this language with the coping skills that were in existence and how these people have been coping with these mental health challenges. For example, when you look at people in Namibia, um, they do not actually seek help because of language, but they don't seek help because they have already seen somebody coping with it, whether this coping mechanism has been a healthy or an unhealthy coping mechanism. They have seen it modeled to them, and they, for example, say, but my father or my mother has been coping with this problem through using alcohol, so I can also do it by just drinking a bit. It was not a problem when I was growing up, and I don't think it is a problem now. So it is a complex thing that has a lot of different factors, but language alone um, sometimes is not the singular factor that influences it.
Okay, so from what the both speakers have said, what I'm hearing here is culture isn't just something sitting around mental health. It influences mental health. How we name it, who people tell, what kind of help they seek, how they share their experiences, and how these experiences fit into what we know as mental health. And this is the part that brings us to the issue of stigma. So I will start with Miss Rani. The question, we often see stigma as one of the biggest barrier in mental health. But what actually creates and sustains this stigma in the community are the narratives. Because people have different narratives, they react and respond differently, and they don't know how it affects the next person. So we are going to say, we say stigma in the context of communities. So I am asking, based on your experience in psychiatric nursing and working with people, when you think about stigma, what are the deepest causes of this stigma? You're muted, ma. You're muted. We can't hear you.
Thank you. Thank you so much. Stigma, very renowned word in the community. But according to my point of view, we often describe stigma simply as people having the wrong attitude. But its roots are much deeper. Stigma can be created by lack of awareness, cultural differences, cultural beliefs, family pressures, attitudes, and the fear of the being labeled as crazy, mad, or weak. In some families, mental health problems may be seen not as an illness, but it is a sign of weakness or character. Our spiritual issues sometimes something that should be kept with the family and hidden from others because this is a question of their honor. As a result, many people delay seeking their professional help. In my point of view, awareness, in this sense, awareness campaigns only and the other currently what we are doing is not enough. We need to understand the people's perspectives and the cultural background to understand their stigmas. We need to communicate their seeking help is not only a weakness but it is a strength, it is a sign of taking responsibility on their health. We need to remove the word stigma by understanding the people's behavior, what understanding about the stigma actually are. And we need to explain what is actually word, and need to take help, and they need to take their responsibility. Most importantly, we need to create a safe, confidential, and private space for the people to explain themselves, to explain, to take help, for not only for their families, not only for their self, but for the community, because their mental conditions are not only a problem of a single person or not only family, but it is a problem of the community. So we need to involve the communities to remove the words stigmas from their lives. So your word, what actually creates and sustains stigma, these are actually misunderstandings about the mental health conditions that make it as a stigma. It is not a stigma, it is a simple conditions like our physical condition, and we work on it with open hearted by understanding it. People.
Okay, thank you so much, Miss Rani. That's to tell us that stigma is not just a problem of lack of awareness. There is something deeper. There are other underlying factors that are happening. So we come to Mr. Alex from an advocacy perspective. Ms. Rani talked about there are social media campaigns, people are hearing about it, but people don't really understand. They know, they are aware, but we see that there's something deeper going on. What do you think we sometimes misunderstand about stigma?
I think the first thing that the first challenge we have surrounding stigma around destigmatizing mental health is what we have started with. Actually, it's language. For example, when you look at um, and it's a very important thing that you mentioned before you came to this section, was that language influences and culture influences how we experience and how we share our experiences and how we share our understanding about mental health. In Namibia, for example, we have 207 psychologists, registered psychologists for 3 million people. And from those 207 psychologists, I think around 37, are native, with the 107, 160 to 107 are predominantly from the white. They have the white background. So there's a lack of understanding also from the educationals on the experiences of Black people, on the experiences of Africans on mental health. When it comes to online campaigns about mental health, is that um, while the information might be relevant, the information might be accurate, the information might be congruent, and the information might actually be very helpful. The language that we use within our mental health messaging also plays a role. So, for example, when we keep on sharing about the clinical name of depression, major depressive disorder, and we keep on talking about generalized anxiety disorder, to a globe or to an audience that only knows about depression and only knows about anxiety, you are sending out the right information, but the audience that you are sending it out is not grasping the information that you are sending. And that also just reinforces the negative narratives that are existing already. Because even though you are giving the people information that would debunk existing stigma, the information does not penetrate with the understanding of the people. Um, so yes, the information that we share is valid, but sometimes people don't understand the language that we use when we are communicating, as I've also already said. And then it means that mental health literacy itself is not sufficient
Yes, sir.
to reliably, destigmatize um, 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 mental health. Also, the problem also that we have is due to fear of exclusion and bullying and victimization. People with lived experiences also don't feel comfortable with sharing their experiences, which also makes it harder for people with African descent to be able to understand how it feels or how it looks like to be somebody that is dealing with depression, that is dealing with anxiety. And when we don't have that narrative, we have to keep on borrowing narratives from the West so that we try and fit these narratives within our African context, which does not help because now, for example, poverty in the United States does not look like poverty in Africa. And the reactions to this poverty are also not the same. So, how the expectation of a person on how that person should react to poverty we borrow that reaction and then we say, but how are you reacting like this while other people are reacting like this? So you are crazy or you are not reacting to poverty in the right way. So that must be something wrong with you. So there are so many complexities, complicated things that might lead, that might lead to discrimination and because now you have been discriminated against, you just start believing that something is wrong with you, then you start stigmatizing yourself, and then you start stigmatizing societies as well. As I was saying, only 150 or 160 from the 207, we only have 30 African psychologists. So now we are also we are also having a very small community of psychologists, and because we have a very small community of psychologists, the discrimination and stereotypes against our people keep on growing because we do not have enough people to debunk those stigmas that exist.
Thank you so much, Mr. Alex. From what you said, I have like two questions I want to ask before we go to Miss Rani. The first one is about not being able to give a name to it. So I want to ask, are there experiences that people actually experience that when they're talking about it, it doesn't really fit into the terminologies that we already have? They come, they tell you some things, and then you don't know if it's depression, if it's anxiety. Are there some experiences as a psychologist you have met like that?
Yes, because the languages are very different. There are times that certain experiences sound the same. For example, when you say in my native language, for example, there is no word that separates joy from happiness. So in my language, there's just one word, or in my language, there's just one word for anger, irritability, and frustration. So when somebody comes to you and they are frustrated or they are irritable, or or they've been, for example, sad for a long time, you cannot actually deduce that this person maybe has been suffering from depressive symptoms for a very long time because there is no word that separates sadness from feeling depressed in my language. So it also comes to the point where people are actually misdiagnosed or people are put on spectrums where they do not fit, mostly because of this lack of understanding and lack of terminology that is there. When I was doing my research, there was a lot of feeling of emotional void, feeling of sadness and grief also, but grief doesn't have a word in my language. So, or grief as we know it in English it does not match to the English translation. So, for example, somebody who had come to you for grief, you would have treated them for depression instead of grief. Or when somebody that had come for anxiety, you could have actually treated them for PTSD. So the language that we have There are so many disparities between the languages and the terminology that exist that one has to be very cautious when you treat someone in your native language, because the language that is being used in the existing DSM and the ICT is very far from the native languages from which people have to share their experiences.
Wow, thank you so much for throwing light into that. Then you talked about borrowing narratives from the foreign land. It's quite different from our experiences here. Are we trying to say that the story we are telling about mental health is quite different from what is happening over there because of our different cultures?
Absolutely. When I was studying, two of the questions that we were asked when I was studying is number one, why is there no book authored by an African that is being used as a recommended book of study in an African university? All of our books that we used were either from the United States or from the UK. And what that does is that automatically, when you are using, for example, what is this group? So this book, yeah, sorry about this. This book, for example, is written um, in the UK. So what I'm doing is I'm supposed to do group counseling and family counseling, learning from this group, from this book. But what I'm getting, the experiences that I'm learning from, is not a Namibian perspective, but a perspective from the UK. But what we forget, number one, is that the cultures between the two are very different. Number one, the Western culture is an individualistic culture, where the family is, I always say, two and a half children, but the most children they have is three, and they are a nuclear family. And when you come to Namibia, for example, is that a family might have six, seven children, and then the family might be extended because the grandmother and the aunt and the sister and the brother and all the other family members might be staying together, in one household. So what that places, number one, it is also places the dynamics of, number one, the family dynamics already is already different, because instead of being taught how to counsel three people, instead of how to counsel, for example, 10 people, you are being taught how to counsel three people or four people. And now the borrowing of the cultures, of that doesn't fit into the narrative that we have here, because the number of people in the family does not fit. Um, and because the numbers of people do not fit, the experience of people do not also fit, because the people that, for example, attend together might be a more communal family. They might be, for example, sitting together and eating. Or, for example, genders might be eating separately. Um, Weekends might be spent separately. Also, maybe the people go out into the field and work in the field, while in the states, a weekend might be young people going to the mall. So it might be different experiences that people experience, but because the writing and the authorship of the books that we use within our universities to be able to register are from the countries that have those experiences, we have to try and navigate how to fit their narratives into our societies, which might not also be able to fit. And I also would like to add another protective factor that I'm also thinking right now of, is like when communities or family members go out together and we call it mango, but through the crop farming, um, it might be a protective factor, because number one, it provides exercise, and number two, it also provides an opportunity for people to sit together and engage into meaningful work, which is part of the definition of WHO. I hope that made sense.
Yeah, thank you so much for expatiating and making us understand that part. That means we need to change how we drive the narrative. We need to change the language we are using. We need to make sure that what we are saying relates to our community. We are not just borrowing perspective from another country into our own to fit. Welcome back, Miss Rani. We come back to you. We keep saying mental health is just like any other illness because we want people to reduce stigma. But do you think that we are actually passing this message enough? Or are we in the course of reducing stigma trying to give them a like below the bar information so they don't see the severity of mental health issues?
Yes, you are right. We need to give right information to the right people. We don't hide the actual right things from the people. We take it as a normal. We need to normalize these all stigmas and these all mental health condition as a routine, like other medical conditions. We try to teach the people in very simple words, but now it is a time to make understand that these are not. These are like our physical condition. These are very much important, and like any other medical condition, these are our medical condition which needs to attention. And in according to my experience, when I talk to the people clearly, like with the mothers, with the young girls, that you have this kind of problem, like a girl in a depression, I talk to very clearly. You are have hopelessness, you are loss of interest, your normal routine, and you also doing nothing which you can do. So these are the simple sign symptoms of the depression. You need to work on it. And believe me, she work on it. And she get back its normal condition. So my students in the different nursing and the midwifery and also my community females, they are openly talk to me and I openly talk to them about the schizophrenia, about the anxiety, about the behavioral problem, about the mania, about the adolescent attention seeking behavior. Each and every time, and this gave me very positive experience that we need to talk about people, like we are talking about diabetes, we are talking about hypertension, we are talking about our cardiac disease. We take it is normal. We need to normalize it, and we take them and give them space that, and we are not judging them, we are not blaming them, because like and other medical condition, they are not responsible. We need to talk about the people, about their diseases. The mental health conditions actually not their fault. Mental health condition actually producing like other mental condition, like other medical condition. So your question is right. We need to talk with the
Hello, Miss Rani. Are you with us? You're muted. We can't hear you, ma. We can't hear you, ma. You're muted. You are muted, ma. Hello. We can't hear you. Your mic is turned off. Okay, so we thank our speakers for those wonderful points. Now to us, our listeners over here, we have heard what mental health is. We are aware, there are awareness everywhere. We have to
so
reduce.
sorry, like
You're welcome
sorry,
back,
Miss
ma.
Victor, like other conditions, this connectivity is also a problem. So we come back. Now we have habits. Now we are habitual for these all kind of problem. So please continue. And your last answers of last question, yes, we need to normalize this condition, and we openly talked about it. We know we don't have need to hidden any kind of the mental health conditions. And you know, very successful figures of the world are suffering from different kind of mental health condition. So let allow the people to talk about their conditions. Let allow the people and give them awareness. This is one thing. This is not a whole thing. Just talk about your anxieties, your depression, your mania, your schizophrenia, your perinatal condition, and take them as you are carrying other conditions, other diseases. So don't think this is a whole life. No, mental health condition is not a whole life. It is simple part of life. It is suitable. It is able to talk with the other people, and it is normal like other medical conditions. Thank you.
Thank you so much, Miss Rani. We know we've heard mental health is normal like every other. But we have family expectations when we talk about culture. We have gender too, influencing. We also have religion. We also have social reputation. So
Yes,
all these strengths and weaknesses, do they influence stigma,
yeah, yes. These are
or do
conditions.
we just say,
No, no.
okay,
These are conditions. Focus. These are conditions definitely influence your language, your culture, your family expectations, your tradition definitely expect from you that everybody doing their normal function in the community, but due to the mental health condition, they are not able. So, yes, these are also influencing on the mental health condition, and we need to work on them also.
thank you. Like in our society these days, we keep saying that the men should come out to talk about their mental health because of expectations. They believe the man is supposed to be strong. As a man, you're not supposed to cry. As a man, you're supposed to be the head of the house. If you're down, who is going to lead?
Yes, but
This
here we
stigma, it's caused, okay, the stigma costs them beyond just seeking for help. It can cost them their jobs, it can cost them their families. So at this point, what should be the protective factors that we should be recommending for societies so that people can look way beyond the stigma and seek for help?
uh, very good question. The first point is prevention from the mental health conditions. How we can create a protective environment and how we can identify the on the very early stage the signs and symptoms of the mental health conditions. Like number one, we need to give awareness and we need to make not only give the awareness to the people, we need to train the people. First, we talk about it. Number one, we need to give awareness about the people what are the mental health conditions. Number two, we need to train the people about like mental health first aid courses. These are very simple courses. We can teach the community. You can identify the early signs and symptoms of these mental health conditions. Number three, we need to collaboratively work with the all healthcare providers, like from family to social health workers, from the community health workers, from the nurses, from midwives. They all have very good collaborative work together to identify these mental health conditions and other refer pathway. Now, what are your second question is also very much important. What are the protective measures or what are the positive behaviors? Number one, we need to have a very positive family environment. And mothers, the basic mental health conditions are uh, provoking due to the family issues. So we need to have a very strong family system. We need to have a very positive parenting. We need to have a very good family relationships. And we also know if any family have a history of a mental health condition, this family must provide a very, very positive environment to their children because environment is very much important to creating and to promoting mental health conditions. Number two, stick on your religious beliefs. Religion also some is a very much protective environment, provide protective environment when you are going away from your religion, you are suffering from some kind of mental health condition. Number three, make it easy to express your feelings with your family members, with your healthcare providers, with your teacher. So it will be very good to explain yourself and you get early identification of your problem and you can go there. Number four, we need to give awareness at the community level. Here, policymakers and the researchers and the practitioners, there is need to provide a community level, a family level interventions. Need to introduce like mental health first aid courses, like how we can control our anxiety, like how we can seek mental health conditions, and we need to provide them different points for the referral, and another productive factor is to do mental health conditions related programs at community level, and we need to involve all stakeholders of the community. I don't take the name of the policymaker at the government level. I want to take this message at the community level that we need to work on the communities. We need to involve from communities. We didn't work for the community. We want to work for the community, with the community, for their promotion of the mental health in the community. So these are the some most important uh, protective measures which we can take to save the not only individual but also community's mental health. Thank you.
Thank you so much, Miss Rani. So we come back to Mr. Alex. Please, are you still with us here?
Yes.
Okay, so from your experience working with people, you told us about having a limited number, 307 psychologists, and we see that that means we have one psychologist to over 1,000 people. So, from your experience, what is something that you have learned from this from your engagement with people that you didn't learn from the textbook? It was quite different from what you were taught in the classroom. It's quite different from what you have seen. If you compare the both of them, you'll be like, how do I attend to this? So
Um, what has been the very interesting and also particularly a very challenging experience for me is translating academic work into practical work. And let me. So, for example, as we have said, we are taught with textbooks that are written in another country, that have perspectives from another culture, that share different experiences. We are also using, um, a DSM or a diagnostic statistical manual in the ICD, which is from the WHO, that are actually mostly not influenced by, the South, the global South. So we are going into a therapy room, for example, where you have to try and navigate and sum up and come to conclusions on information or on data that you have collected from the client, which might not match the information that you were taught with. Um, and also, what I've also learned is, and I think Dr. Rene said this in the beginning, is that the case by case, therapy, psychology, mental health, even though we have, you know, um, definitions available, even though we have diagnostic criteria available, even though we have research on what certain things, on what, for example, depression should look like, on what psychosis should look like, on what mania should look like. Um, the real world experiences or expressions of those symptoms are so much different from what you would find them in the book. There are people, for example, we have been told that people with severe psychosis cannot function or work within a community, but then you'll find people with schizophrenia that are on medication and that can actually live a fulfilling life with that illness. We find people that have a bipolar that we have been told that they need to be hospitalized permanently, but they are actually living fulfilling lives. So, when you look at what you are provided by the textbooks or for what you are being told by your lecturers, and when you go out into the real world and experience the practical aspects of this illnesses or these expressions of illnesses, and then you see that, but this is not I was taught. So now you have to reteach yourself sometimes, or just to redefine certain things for yourself, so that it just fits into a narrative where you are able to be flexible and say that, oh, but this person really might be suffering from generalized anxiety disorder, but they are able to function in this world. Or this person constantly has panic attacks, but they are able to function in this world and have a fulfilling life. So instead of giving the methods that I was taught to assist the people, how can I mold this to fit the individual that is sitting, that is standing in front of me? So I think is something that has really come up in that when we talk about individual, I think also comes into play. How does this community, how does this culture understand these various disorders, or how does this community or individual understand the expression of these emotions? Like Dr. Ren was also saying, for example, some expressions, for example, of what we would say is a mental health disorder would be, for example, seen as a spiritual awakening, or a traditional or an ancestral visiting. So how do we navigate this individual and this community where we are in, and try to apply or make sure that what we were taught fits the individual or the community that we are serving? Because I think the most important point that we must understand is that even though we are taught, the individual and the community that we are serving is very important. I mean, I think they are the one that guide and direct how we should go further.
Thank you so much. So we come to Miss Rani. What has your work with patients, families, and community taught you that clinical training alone would not have prepared you for?
They taught me a lot. I agree with the Alex that what is actually in the books, it is very difficult to implement in directly in the community, with the families, with the individuals, because reality is sometimes totally different. What you have taught and you are very happy, you will apply to so and so this, like I have assessment criteria, I will go to there and will no. They have their own behaviors, they have their own cultural attitudes, they have their own expression, and we need to fit in their expression, in their culture, in their family values, and we will find out the actual situation. So at this point, we only remember the basic definition. Other signs, symptoms, we collect them, we come back and we relate them. So Alex is very good. He is totally right. The experience is excellent. So we theoretically we were very excellent in that theory, but in reality, communities' behavior is different. Individual behaviors are different. Families' behavior is different. And from one community and other communities, and from one woman to another woman, from one adolescent to another adolescent, we have different behaviors. So this is our intelligence, how we can identify their different behaviors, how we can give them different categories, and how we can also keep safe ourselves in front of them. Because they know about that, we have identified them, sometimes they become very different behaviors. They don't rely on them that you are their friends. So whatever we read in the books, sometimes it is totally different. But actually, these practical taught us from the community what are the mental health conditions. We learn from the females' behaviors, from their physical conditions to their mental health challenges. We reach there. Like I find out mood swings from of pregnant women, and I find out many conditions from this woman, and we totally and I find out the sign symptoms that are somehow different from the bookish knowledge. Number two, I find out different sign symptoms of the depression in the adolescent. One adolescent always suffering from the severe headache, severe headache, severe headache. Actually, that is not a severe headache. That is a critical symptoms of the isolation, and leads to the depression. So, sociopathic behaviors we find out in the families. So your question, our textbooks are very good, but community teach us actually their original mental health conditions from A to Z, and these are actually real experiences which make able to identify the different. Like I am working in communities as well as I am teaching to the students. So they told me this behavior. I told my students, you go back to the community and you will assess the females with the pregnancy and also location, and you will identify also adolescent. After giving training of the mental health first aid course, they go back, and when they come back, I find out lot of stories. And even two of these students also find out their behaviors that we are suffering from depression, number one depression, number two anxiety. So communities teach us what are actually their challenges, and how they are suffering from different kind of mental conditions. And actually these conditions are also give the message that we should include our experiences with the other organizations that are involved in the writing these kind of books. And so thank you so much.
Thank you so much, Miss Rani. We hear when they say you want to create a mental health intervention for a community, you go to the community, you assess them. You don't just create an intervention, but you create it for the community and by the community. And that
Yeah,
is why we are including the mental health dialogue series from the first to this point. We
yeah,
want to we want to know that our evidences, what we have found out, all the information and conversations we are saying, we can take them to the communities.
yeah,
But are we consulting these communities? Are we engaging these communities? Are we designing the solutions for them? Or are we just walking by the books because the books say so? What do you think we have overlooked so far in the community that you think we should uphold as our priority right now? I'll start with Miss Rani.
yeah. Ms. Peter, excellent question. Actually, this is a point where we take a note for the take a note and the message for the higher authorities and other researchers, practitioners, and the policymakers. You are working for the community, but you are not working with the communities. We need to working with the communities. We need to working with the communities by involving them not as a participant but as a partner. Because they are actually suffering from these conditions. They are actually the stakeholders who are holding these conditions. So we need to take them as a partner. Right now, we are not going on the right way. Here is a one message from your platform that if we want to create a healthy community, if we want to create a healthy family, we take them as a partner. Number one, we need to listen very carefully to them. We need to assess carefully. We need to messages from them, and also we can take solutions from them. Also, we have a very good pilot studies, but every pilot study is not fit for everybody. There is need to read well. Uh, Again, a pilot study for the target population. So, if we want to work for the communities, definitely we need to involve the communities. from day one to day end. Either we are going to develop any, we are going to write down any book, either or we are doing any research, or we are developing any kind of checklist. We need to involve the community as a partner. Number one, we take them as a full-time stakeholder, and also we need to take their religion, their socio-cultural values, and their other important aspects of the community. After that, we can get success, and we can go to strengthen their mental health conditions. This is my simple message. Thank you.
Thank you so much, Miss Rani. Mr. Alex, over to you.
Um, w- 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 one of the things I've seen with when it comes to community-based or community-centered interventions is that when people come to communities, whether they are NGOs, whether they are doctors, whether whoever comes to communities, they tend to come as experts into that community. They know everything about the community, and they come there as if they are the ones that are going to be providing the solutions for the community, or they are the ones that are going to be saving the communities. Unfortunately, what that usually happens is that you come there as an expert without involving the community, and most of those projects either tend to fail or do not produce positive results. What we have studied, or what we know in psychology, there's as a research, a type of research called, there is a community-based participatory research. It's CB CBPR, yeah, CBPR, and it's totally just it like Dr. Reno says, it involves community as the stakeholders who are part of the planning, the identification of the problem, the designing of the intervention, and also the monitoring and evaluation. They're also part of it because the problem is affecting them. So you are there to just assist them in finding a solution to that problem. And when you go to that community, you are not going there to change their religious beliefs, their cultural standards or norms, or any other existing value that they might hold. But you are just going to help them, if the problem is, for example, their religious beliefs in those things, they are the ones that have to work on that and change them themselves. It is not you to go and change the existing structures and systems that are already in place by the community. And one of the important things also with the community-based participatory research is that um, when you go there, eventually you are also um, should have an exit strategy, so that when you leave that community, the community is able to sustain themselves with the solution that you left them with. So if it must not be when you leave the intervention falls apart, but when you leave, the community is able to sustain the solution that they came up with together with you. That would be my addition on that.
Thank you so much for the responses. You see, as mental health expert, public health professionals, when we get to a community, we want to how will I put it? We want to make the community to fit into the mental health system.
Yeah,
Meanwhile, we are supposed to make the mental health system fit for the community. So these are narratives we need to start changing.
yeah,
These are things we need to start doing instead of promoting what we have been learning. We should promote what the community will benefit. Like Mr. Alex said, when we leave the community, the intervention should not fall apart, but rather the community should be able to sustain it, because we have taught them, we have done it for them, so it is part of them to work. So thank you so much. We have talked about the culture, we have talked about stigma, we have talked about community knowledge and experiences. So now we are going to bring all that together for our final question. If we want mental health solutions to become genuinely and culturally responsive and community-centered, what is one thing every researcher, policymaker, practitioner, advocates, community health workers, environmental advocates, what is that one thing they need to do differently? We'll start with Ms. Rani, please.
Okay, thank you so much. Before to giving answer of this answer, I would like to share my experience. Whenever I have started to give training to the lady health visitors, that is actually community health workers and the community midwives, I personally involve mental health first aid course to their curriculum. Even they don't ask me, I include it and I taught them. Can you believe it? They are so much interested to learn this course. And I, after training, I received many messages that they have identified different females and they refer them. So this is very much important. Whatever you have projects started in the community, you must make them able to live with sustainability. Without waiting for you, you come back and you will continue with them. So let's come on your what is the responsibilities of number one researcher, number two practitioners, and number three policymakers. I think one of the biggest change we need for at this stage is doing things for the community. Uh, we need this sentence: do things with the communities. With rather than we are doing things for the community, we need to do things with the communities. This is my strong words by your platform. How? Number one, researchers should involve the community members from beginning of their research process to their implementation and evaluation. To like in my one research, first we need to go to deep rooted knowledge about the community. And according to deep rooted knowledge, we need to design actually research, and then we can implement and we get a very good result. Number two, practitioners should look beyond clinical symptoms and also consider a person's family, culture, social environment, and the life experiences. This is very much important because mental health challenges is not only in the mental conditions of the patient, it is also a mirror of their personal families, culture, all the social environments, behaviors. Number three, policymakers need to develop policies that reflect their realities on the ground and integrate mental health services into the primary health and the community health services. This is the one of the most important. Mental health conditions need to be integrated into primary health care level because, and even in this, I also suggest that it is mental health conditions also integrate in the scope of work of the community health workers, including doctors, including nurses, including communities. So they are working at the community level, so they can identify the patients. And actually, first identification is one of the most important steps to start implementation and refer to the client with the mental health condition to the tertiary care level. So these are my suggestion. And the last, but not the least, I believe currently responsive mental health care become possible when we stop creating solutions for people and start creating solutions with them. So my last message is start to work with the communities. So we will get successful. Thank you so much.
Thank you so much, Ms. Rani. So we'll come over to Mr. Alex.
I do agree with everything that Ms. Rani said, and I don't think I'll repeat it all. Particularly community-centered, interventions that are focused on communities as stakeholders, formulators, and implementers of solutions, and also evaluators of the success of those projects themselves. One thing that I wanted to reiterate that you said, but it just slipped my mind. But I might think of it as I'm saying is, but when we are talking about community, when we are talking about mental health in general, I think because of the newness of the concept within the African context and within the global South context, I think we should approach it more with curiosity on what are the possible meanings that it might hold for us, and not approach it with preconceived or predetermined definitions of what we are seeing on social media, or what we are hearing on social media by people that have already experienced and having a long-term exposure to mental health. Because I think mental health in itself in the global south has actually only been reactivated and reinvigorated by the COVID-19 pandemic. I think before that, a lot of us did not know what mental health was. A lot of us did not even know what a psychologist was. So I think the concept of mental health in the African context is very new, and because it is very new, we are trying to create, or we are trying to lean on and hang on to existing narratives and explanations that do not fit us. So I think we should approach it with a lot of curiosity, and trying to see how does this fit in my community. And even if we take, for example, the World Health Organization's definition of mental health, how does that definition, translate and reflect itself within my community? How does it mean, or what does it mean to to live well within my community? How does it mean to contribute to my community, in this with my cultural context, and not from the cultural context where the definition was coined, or when we look at it from a Western definition. So I think we should approach it with a lot of curiosity. I think we should also be able to have a lot of flexibility around it, and be able to say that, what I learned today might not be true, might have been what has served me then, but what my community needs tomorrow is something else. And I am able to be malleable and be able to change myself to that and adapt to this new experience that I'm experiencing. So flexibility and curiosity, I think those things are, I think, an important community psychology. I'm going to reiterate and say within African and global South context.
Thank you so much. Thank you so much, my honorable speakers. We have learned a lot. We have brought out a lot of discussion. At this point, we'll leave for a few minutes questions from the audience. So, as we wait for others, I have one question here. And when Mr. Alex talked about flexibility, what is one thing you think young people understand about mental health that older generations sometimes miss?
I think one thing that older generations missed, or that they do not understand, is that mental health is something that exists within us all. And also that mental health exists in a continuum. I think and when you go to rural areas within countries, you will be able to see how that manifests, or how that understanding manifests itself, is that people still associate mental health with psychosis or mental, and not just normal mental illness or depression where people are functional, but where psychosis to the point where people are hallucinating and delusional. So people still the older generation still associate mental health with that type of expressions, that expressions of psychosis. While young people are more understanding of mental health, are more understanding that it exists on a continuum. But what has happened also is, and I'm going to be honest right now, is that because of the disparity in understanding of mental health, what young people I'm not saying all of them, but a majority of young people are doing is that they have taken the understanding of mental health of all people, and they are using it to manipulate them by coining and saying, but if you are doing this, you are affecting my mental health, or you're impacting my mental health negatively, just so that they might get their way, get out of chores, get out of, doing something, or, trying to get out of punishment, or guilt tripping, the older generations in getting what they want. But I think the definition in itself, that is where the disparity lies. How people understand mental health. Younger people understand it as it might, for example, be existing on the WHO definition, but older people are still viewing it as psychosis, illness, expression of delusion and hallucinations. That is what I see it as.
Thank you so much. We have one for Miss Rani. If you could change one thing about how mental health is discussed or addressed in your community tomorrow, what would you change?
I would like to change the health system and education system. I would like to provide, especially the healthcare system, and that is primary healthcare level, because I think this is a one of the most important missing step. We didn't focus on it, and the minor mental health problem could become the major healthcare problem. And the second thing which I would like to change, that is the education system. Realistic, I just want to realize the people education is not only to getting a good number of the in the exam, it is actually to make clear your concepts about the different conditions. So these are the most important things. And through health education, I would like to make a responsible citizen, a responsible male, female for the society. I would like to recommend to start mental health conditions from beginning of your education system, like other reproductive health systems and the chemistry and the biology and the physics. We need to start our mental health condition to discuss with the children also, because it start before birth of a baby. So these are the my I wish to need to change.
Okay, thank you so much. I think that's the last question we have here. So we have spent today talking about evidence, culture, stigma, community. And I have one last, just very short for everyone. As our take home for today, what is one thing you want everyone listening tonight to rethink about mental health? We'll start with Miss Rani.
Yeah. Uh, we need mental health is very much important. We need to keep our mind a very safe and meaningful asset for us. We as adolescent work for it. We as a pregnant woman work for it. We as a man work for it. We as a elderly woman or men, we work for it. How? Number one, we leave all things which disturb us, either their behaviors, our relatives, our social media, or any activity which disturb my mind, I must leave it. Number one. Number two, we need to promote a very safe environment for my mind. This is for all, and this we need to repeat it for all. As I myself try to take a very good sleep, try to take a very good nutrition, avoid negative and toxic people, provide always a very good positive environment for me, a very good exercise, a very good relationship with the family, with the co-workers, and for the society. These are very simple. Thank you so much. And this is my message for
Thank
all.
you.
To work for your mental peace. Thank you.
Thank you so much, Miss Rani. Mr. Alex, over to you.
I remembered what I wanted to say. We should also understand that when we talk about mental health, the important thing that we should also remember is that it is not always psychopathology. It is not always about mental health disorders, or it is not predominantly about illnesses, or going suffering from a disorder or something. Mental health, transcends more than, and I think the conversation also needs to move beyond that, where we see mental health as something that exists on a continuum. You can have good mental health and you can have bad mental health, but we all have mental health. I think that is what I wanted to add to what Ms. Rene was saying before this. What I would want to add, the thing that I would want people to ponder on is, what does my mental health look like today in this present, based on the understanding from what I've learned today? And how does my culture impact my mental health, and how does my mental health also impact my culture? I think that is a very important question to ask ourselves. And also, when we go out to do something, also an important question that we can ponder on is, how would this question, for example, impact my mental health, and how would what I plan on doing impact or contribute to my community? I think those are important things that we should talk about and think about on mental health. And then another thing that we should, within communities and with each other, is to offer ourselves a lot of grace, because we don't know what other people are going through. We were taught when we were doing our when I was doing my training, we were taught an important question that you should be asking yourself before you judge someone is, what must it be like? I can only imagine. So before you draw conclusions about other people and draw conclusions about even your mental health, what must it be like for me, for example, to be unemployed? What must it be like, for example, to be living in poverty? What must it be like, for example, to living in a rural area? So that you are just offering yourself grace and not just self-judging and self-criticizing and self-stigmatizing yourself over things that are predominantly products of your environment and not products of your own doing. I think that is what I would leave people with.
Thank you so much, Mr. Alex. Thank you so much, Miss Rani, for sharing all your experiences, your perspective, and importantly, your challenges to the way we see and talk about mental health.
Ms. Victor,
So, as we close,
I just want to add one sentence. As I am listening,
okay.
Alex, that is excellent. We need to, as a mental health provider, we just need one action. We must be a good listener. When you listen to someone, most of the problem has been solved. And just to give one guideline, you should do this. And it is my life experience. I am a very good listener and very good observer. Just I give 5 minutes to 10 minutes to the you should and this is whole act, but it create a big change, and it create a very positive environment, and it change a people's life. Just start to take this message to you all. You must have a very good listener, maintain confidentiality and privacy of the people, non-judgmental behavior, very positive facial expression, and very good positive environment. Thank you. And you can change your surroundings. Thank you so much.
Thank you so much, Miss Rani. We must all learn to be good listeners. For us to be able to provide solution, we must listen, observe, and be positive towards the person. Because once we are biased on our own, we might not be able to put ourselves in the shoes to understand what is happening. So, thank you so much. Mr. Alex has told us about flexibility. You really don't know what people are going through. And sometimes we overjudge ourselves, not considering that some things are from our environment, they are beyond our control. So, thank you so much for all those wonderful points. As we close today, I think there's something powerful about where this series has taken us from or
Yes,
taken us to, because we started from evidence to action. We
yes,
also looked at mental health as a human right. And
yes,
we had a session, or we had Mr. Alex on that session where we talked about technology closing the gap. Because of the age where we are, we think that technology can do it all, but we see that there are gaps that need to be closed by humans.
Yes.
You need a
Yes.
human to listen. You need to
Yes.
feel like someone understands what we are going.
Yes.
And
Yes.
tonight, we came back to the fundamental: people and the community.
Yes.
We know
And
that evidence matter. We also know that rights matter. We know that even the technology matters. But we know that these things cannot exist outside people and the community, because this mental health is for the people, it is shaped by culture, and it is affected by stigma. And then
yes.
this community experiences all these things. So we
Yes.
can say the success of any mental health solution depends on the lives of the people in it. That's why Miss Rani told us that we must do it with the community. We can't just be creating solutions. We must do it for the community because it is intended to save them. So perhaps from this series, we don't need to choose between evidence or right or technology or the community. We need all four of them. We need evidence. We need the evidence to be rigorous. We need the
Yes.
system to recognize mental health as a right,
Yes.
because, like Miss Rani told us, there are some cultures that don't favor, especially the genders. Some
Yes.
people cannot receive help because of gender disparity. And so
Yes.
we can also use technology which is usable and equitable, but it doesn't completely or 100% fills that gap. We need
Yes.
solutions that listen, respect, and they are shaped by the communities. So, on
Yes.
behalf of the Mental Health Dialogue series, I want to sincerely thank everyone for joining us in this conversation. Thank you, my able speakers. Thank you, my
Yes.
participants, our audience, everyone who has asked questions, shared, or contributed to this dialogue series. You have been part of this, our journey from the first session till tonight. Thank you for showing up for mental health. And I hope that this conversation doesn't just end with what we're telling you. You can take it back to your community, to your institutions, to your workplaces, to your family, and
Yes.
most importantly, to the way you as an individual responds to this. I hope you'll join us for our next series. And we know that this is just the end of this particular series, but it is not the end of the conversation. So, my
Thank
name
you.
is Owo Victor. I'm the anchor of Mental Health Dialogue Series Part 1. The Part 2, you get to hear about us. You get to hear about it. You receive emails or chats, whichever one you have subscribed to. We also have other dialogue series on the FIRAD platform. We have the maternal health, we have the dental oral, we have the nursing conversation. These are conversations around professional communities. They help us to see evidence. They help us to see what is going on in our communities. They help us to see how we can provide help or interventions that are beneficial to our community. So thank you so much once again as we come to the end of this series. Have a lovely evening. Have a lovely new week. And thank you again. Bye.
Thank you. Thank you so much. Bye.
All right.
Thank you.